Care as One is committed to providing a unique virtual collaborative experience for healthcare professionals to come together to exchange information about U.S. healthcare through collaboration, conversation, and knowledge sharing. The Future of Health podcast provides a true infotainment service that helps the industry innovate by sharing expert voices, views, and advice on the important issues of the day. And now here's your host for The Future of Health, Dipty Desai.
Hello everyone. Welcome to The Future of Health with Care as One. I'm Dipty Desai, the Director of Care as One and the host of this podcast series. For those of you that are new to Care as One, it is a large virtual community that brings together various stakeholders in the care cycle, from providers to payers, pharma to clinical researchers, startups, investors, universities, and more. The mission of Care as One is truly to care as one by creating a connected healthcare community where the patient is at the center of care. The entire ecosystem comes together to care as one through knowledge sharing with the help of healthcare luminaries and thought leaders to discuss the challenges, gaps, solutions, and transformations essential to make healthcare whole again. The interactions and networking between the stakeholders is made possible through the community via summits, webinars, roundtables, leadership circles, and yes, podcasts. In today's podcast episode, I will be talking to Dr. Robert Pearl. Dr. Pearl has served the Permanente Medical Group for 18 years. As many of you know, the Permanente Medical Group is the nation's largest physician group. He is also a healthcare contributor at Forbes, a bestseller author, and a professor at Stanford University School of Medicine and Business. His new book, Uncaring: How the Culture of Medicine Kills Doctors and Patients, was published this May and is receiving industry-wide praise. His experience and contribution to healthcare is unparalleled, and today we will be discussing the role of technology in the post-COVID era. Dr. Pearl, it is truly an honor to host you. And to begin with, can you please tell us a little bit about yourself and your career, your journey at the Permanente Medical Group? We would also like to hear about your new book, which tells us what brought you to where you are today and shines light on the unseen and often toxic aspects of medicine. So before we jump in to address the role of technology in post-COVID era, we'd like to hear about this journey of yours.
My journey was a series of, I'll call them serendipitous steps. I went to medical school at Yale and then came to Stanford. I'm a plastic surgeon focusing on children with birth defects, particularly cleft lip and cleft palate. Mm-hmm. And I actually got my job at Kaiser Permanente when the plastic surgeon there unfortunately died in a tragic plane crash. I didn't even know it existed. And I received the call. I was about actually to travel to South America and fix kids with birth defects. And I said I'd come for 6 months. And the next thing you know, here I am in my career, spending it all at Kaiser Permanente. And similarly, I was chosen for various leadership roles, became the head of the biggest of the hospital systems, the one in Santa Clara. It cares for about 500,000 people. And then when the CEO in the late 1990s left the job, Kaiser Permanente was in big trouble at the time. I wasn't particularly looking to become the next CEO, but with the urging of others and the reluctance of some to take on the role at that time, I was chosen, and I had the privilege to spend 18 years as the CEO in Kaiser Permanente, head of the medical group there. And across that time, we were successful. We went from quality that was good to quality that was number one amongst 1,000 programs in the United States. Service that I would say was lagging, and we went to being a leader, 20 points above anyone else in California on J.D. Power Associates. And when I took the job, we were in financial trouble. We were down to 2 days of cash. We had to borrow a day of cash just to stay in business. And by the time I left, we were very, very solid. And I was the leader both on the East and the West Coast. After 18 years, the time had really come to, I'll say, expand, take what I had learned in Kaiser Permanente and offer it across the nation. My first book, Mistreated, Why We Think We're Getting Good Healthcare, We're Usually Wrong, which was a Washington Post bestseller, focused on the systemic issues. The broken healthcare system, fragmented, paid on a piecemeal basis that we call fee-for-service, using technology left over from the last century, although actually from the century before, because the fax machine is how physicians exchange information, an 1834 invention. And there wasn't any leadership, any structure, any way to make major change happen. I became interested and wrote the book on caring 3 years later. This was December of 2019. The federal government announced that healthcare costs would go up 5 to 6% a year, every year for the next decade. I did the math. This is compound interest. Healthcare costs were going to rise by $2.5 trillion. I said, could we use this money better? Could we use it for managing patients or helping patients with chronic disease? Could we use it for pre-kindergarten education? Could we use it for the social determinants of health? How could we use it? And I waited to hear from the medical organizations about their thoughts on alternatives to simply putting $2.5 trillion more dollars in the American healthcare system, but by the way, which is amongst the 12 industrialized nations last in life expectancy, last in childhood mortality, and has the highest maternal mortality of any nation in the world, and the only one where it is rising, and nothing changed. And I said there had to be something else, not just this broken system of medicine. And that's where I traveled around the United States. It was just before COVID, spoke to hundreds of doctors, and it was clear that the culture of medicine, this invisible force, as powerful as gravity, but just as invisible, was in play. Now, I don't want any of your listeners to think the book is negative. I love the culture of medicine. It's what made doctors heroes. It's what allowed us in COVID to go to the ER, take care of patients with this coronavirus. We didn't have the protection we deserved. We had to put on garbage bags in place of gowns and salad lids when there were no masks. We intubated patients. We passed endotracheal tubes into their lungs. And we knew that every time the tube went through the vocal cords, patients would cough, spewing the virus in our face. And we did it anyway. We've made remarkable advances in science and in knowledge and in care. We should be celebrating this culture. But we also need to acknowledge its downsides. We have to acknowledge that we haven't valued prevention of disease and avoidance of complications with chronic disease as much as we've elevated intervention. And we saw it in COVID-19. We saw patients who were dying. 88% of those in New York had 2 or more chronic diseases that we had not managed as well. And I compared that to my experience in Kaiser Permanente. Take as an example, hypertension, which was the leading cause of death from patients with COVID-19, a leading associated chronic disease. Across the nation today, we manage it effectively, control it 55% of the time. In Kaiser Permanente, it was over 90% of the time. Now, we had really good doctors, but so did the community. Great drugs, but so did the community. The difference was this culture, a culture that not only valued prevention, a culture that not only worked together in a collaborative, cooperative way to achieve better outcomes, but also a culture that valued technology, the focus of today's conversation, and that we were able to use that technology in ways that others had not, allowing us not only to achieve superior outcomes when it comes to chronic disease, but overall lower mortality from heart disease, half of the national average, lower mortality from strokes, 40% less than the national average, This is the power that happens in a culture of collaboration and cooperation and very much impacts the choice and the success of technology.
So true, so true. In fact, what you alluded to, how Kaiser Permanente was pre-90s and how it transformed post-90 is truly remarkable. I think many of the people I talk to also managed to say that, wow, really, Kaiser Permanente has transformed itself. And now I realize that it was during the era where you took over and you made that change possible. Truly illuminating conversation here. So I'm sure our listeners are enjoying it too. Now, you mentioned that in the future, digital transformation will play a critical role in the delivery of healthcare, and access to real-time accurate data from IoT devices and AI-based solutions will be key. Can you shed some light on how these solutions will become the cornerstone of integrated healthcare systems of the future?
Absolutely. And people who want more information, my website's robertpearlmd.com. They can go there. And one thing I forgot to mention is all the profits from my books go to Doctors Without Borders. So that's a worthy cause that I'm hoping all listeners will be supportive of in the future. So, this is a immense area of technology, but I'd put it into three buckets. First, to me, is the electronic health record. Second, it's the ability to have data input, whether that comes from wearables or other devices at home. And then finally, it's the ability to connect with patients using telemedicine. And we'll add on later on artificial intelligence, data analytics, and some of the other tools. The first thing I'll say is that you can't provide great care unless you have a comprehensive electronic health record. And we put into Kaiser Permanente early in the 2000s, long before other people did it, a cost of $1 billion. It's very expensive to do, but it's part of how we could achieve these better outcomes when it comes to both avoiding and preventing complications from chronic disease. But I think the second part, and we're learning it now, is that the healthcare system of the United States was really built on a time when all patients had were acute problems. But right now, the biggest cost in the United States, the biggest cause of death is chronic disease. And you can't monitor care for chronic disease on a calendar basis. I'll see every 3 or 4 or 6 months, whatever it's going to be. You need to have continuous monitoring. And that's where the various wearable devices, that's where the various home tools, that's where patients can enter the data into a computer system, but you need to have an approach that allows it to be continuously evaluated. And the United States today, doctors can't do that. They're too busy. They don't want all this information coming into their office. And what's missing right now, I think, in the United States is an intermediary. And you can't have people doing it. It's too expensive. This is where we need to have technological solutions to manage that data and be able to curate in a way that physicians and patients can both know everything is good or it's not good. And then we shift. I don't say I'll see you in 3 months or 4 months to manage your diabetes or your hypertension. I say you'll be evaluated every day technically, and then I will see you. I may see you a week from now because there's something that's not going well, or I don't need to see you for almost a year because everything is great. Now, the other piece is going to be telemedicine. During the pandemic, as you know, telemedicine went to 60-70% of doctor visits. 7 years ago, I wrote an article in Health Affairs. At that time, I talked about the fact that in Kaiser Permanente, at that time, we were doing 12 million virtual visits a year. And I predicted at that time that 30% of what we do in the doctor's office nationally would be done virtually. And I waited. Nothing happened until this pandemic arrived. And then, as we said, we saw it soar, although now it's dropped back down. If you don't count mental health visits, which is the most common use of telemedicine, it's down to somewhere between 11 and 19%. But that's the idea that what telemedicine is it replaces a single doctor office visit is a underestimate of what is possible. It may be 10% of the solution. Most of it is that telemedicine video solves the problem of what I call distance and time. What's some good examples? What happens across the United States today? 6 p.m., 5 p.m., doctors close their office and they put out a recording that says, if you're having an emergency, go to the emergency room. That's the first place you want to be if you're having a heart attack or stroke, but it's the last place you want to be for the kind of problem that during the day would have been treated in the doctor's office. What do we do in the Mid-Atlantic Permanente Medical Group? We have a physician available to do a video visit 24/7, and 70% of the time after nights and on the weekends, that individual solves the problem. And should there be a real emergency, not only will the physician tell the patient go to the nearest emergency room, but he or she will contact the doctor there, provide all the medical information off the electronic health record so that the care provided becomes even better. What else? Bring the specialist into the primary care physician's office. You know, most of the time when the primary care physician has a question, they have 95% of the information. They just need a small amount of additional data. What an opportunity to have a specialist available to provide care to large numbers of primary care physicians. This is not a doctor and one doctor in specialty and one doctor in primary care. It's a leveraged model. So again, we did this in Kaiser Permanente. A great example is dermatology. Now, most of the rashes that primary care sees, the doctor solves the problem. But sometimes the individual isn't quite sure what's going on. We took a digital picture, or had the physician's assistant take a digital picture. They were trained in it. It was sent to a dermatologist who could then establish the diagnosis with the personal physician seeing the patient. And we solved the problem 70% of the time in 6 minutes. Now, I don't know what happens where you live. Most of the United States dermatology is 6 days, 6 weeks, or 6 months.
Waiting.
Higher quality, more convenient, lower cost. And the same thing happened at about a 40% rate when we brought in a cardiologist or a GI doctor into the office virtually. We could resolve the patient's problem. And when it couldn't get resolved, we could start the evaluation and workup. So when the patient saw the specialist, it wasn't the start, it was the middle or the end of the process. Telemedicine can revolutionize American healthcare, but it's going to require that physicians be willing to use it to its maximum. And that's where the culture comes in. You know, what do they say? Leading doctors is like herding cats. You know, we don't like to be told what to do. We don't all like to agree on the common approaches. We love our autonomy. We like doing a little bit of everything. This is the culture I think that needs to evolve. And I'll offer you my own thought, which I think that much of burnout today is this clash inside of a culture left over from the past against the reality of today. The patient is the consumer. The patient is the individual who uses the internet to get data. The patient who's demanding some of these services. I think if we can evolve the culture and evolve it in a way, and I'll say by moving from a fee-for-service system into a more capitated one that will reward us for preventing disease as much as intervening, I believe that we can eliminate a lot of the burnout that today is happening, particularly in primary care.
No, that's so true. You brought the point to the front that you really need to change the culture as the physicians are getting older and the new ones are coming in. They're actually adopting technology much faster. And we really need to see this not only happening in pockets like Silicon Valley or in hospital systems like Kaiser Permanente, but it needs to spread throughout all the hospital systems and throughout the country. You also mentioned, physical versus virtual. And of course, there is a new term that got coined, which is phygital, right? During COVID. So the blending of the physical and the virtual and how that interaction could play out to the doctor's benefit too, and the patient's benefit too.
I
So,
think much of this is going to require the evolution into teams of doctors working together. By the way, with other healthcare professionals, I often talk about physicians for two reasons. Number one, I think they have to lead the process. And number two, I think they're often more resistant to some of these changes because of the physician culture. But it's to require teams. You can't provide 24/7 coverage to patients without a large number of doctors, 20 or 30, because no physician can be on call 24/7 or wants to be available at nights and weekends. But if it's shared broadly enough, you can't have the specialist be willing to come in and solve the patient's problem virtually if economically that's going to take away the referral and cost them money. No one's going to do the things for which they are going to be personally, financially hurt. And that's where I see the evolution giving care that is more rapid, higher quality, and lower cost, with an ability to share the savings, both between whoever's organizing the system and the doctors providing the care, and between primary and specialty care as well.
and you also brought out another point, which is transitioning from fee for service to value-based care. And there is this huge hesitancy or reluctance to move from one to another. I mean, what do you think needs to happen in order for people to feel more comfortable to adopt value-based care? Can you suggest some things that hospital systems or physicians can do so that they're more sure about the payments they will receive and this equity of sharing?
What I can tell you is that it's going to happen, and I can offer some thoughts about the different ways that it's going to happen. The first thing is it could happen through the medical system itself. And you're seeing this. You're seeing quite a number of, I'll say, organizations that started virtual first primary care expanding. Oak Street Health is a good example that now acquired Rubicon, a specialty application. You see 23andMe acquiring Lemonade. You see the medical care outpatient organizations linking together with Iora Health as an example, linking together with other systems. There are a lot of opportunities that we're seeing in the world there, and they could evolve into a capitated value-based system. It's particularly happening in Medicare Advantage. The second way that it could go is that the large self-funded businesses could decide that they're going to do this. And to me, it's a warning. You know, we are seeing this now as an example. PBGH used to be Pacific Business Group on Health. It's now the Purchaser Business Group on Health. They have an entire wing or component of their organization. And these are the biggest employers who have now decided they're going to move to value-based care. And they're starting in the pharmacy arena, but they're going to go into the care delivery. And Amazon. 3 years ago, Amazon joined with Berkshire Hathaway and JP Morgan Chase to provide care, they said, to their 1 million employees as a not-for-profit. I wrote in Forbes, anyone who believes that probably believes that Amazon only sells books. No, they're doing this as a means to be able to have 1/6 of healthcare the same way that it has 1/6 of retail. That's Jeff Bezos' view. And look what they've done. They have PillPack. That's a pharmacy system. They're offering telemedicine now at a national level. If you live near one of the facilities, you can use their on-site clinics. It's not hard to see how they're going to evolve. And any physician or hospital that believes that what's going to happen is that they're going to include all the doctors in the community, all the hospitals, doesn't understand Amazon. That's not the way they do business. They're going to find the best, and they're going to make sure it's done at the lowest cost. And if we don't get on the train, I think that doctors are going to get left behind. Now, I do want to say for your listeners that I think that today there's a battle going on between, I'll call it private equity and venture capital. Now, many of your listeners may not be as familiar with the business world. As I say, I teach not only at the Stanford Medical School, but the Stanford Business School. The private equity world looks to have a 3-year turnaround. They've come into the industry and they said, if we can get every urologist or we can get every GI doctor in the community to join, and we can pull cost out and control the market, we can raise our prices and make a lot of money. That's their model. It says, I'm going to use the old model and put it on steroids, the same way hospitals are coming together to be able to control the market and raise prices. We can do the same in the physician world. And they're buying doctors' practices, or 30% of doctors' practices, and they're paying about 15 times the revenue of the previous years, the profit of the previous years. At the other end, though, are these private equities. These are the ones that are funding the Oak Streets. These are the ones that are responsible for Teladoc merging with Livongo to be able to provide not just urgent care, but chronic disease. And they're taking a longer view, probably somewhere in the 5 to 10 year range. And across that time period, what you're going to see is going to be this move very much to value. So there's a short-term fee-for-service, a long-term value, and when to leap from one to the other if you're a hospital or a physician is going to be a hard call, but it's not going to be easy and smooth. I mean, in the question you posed to me, you made it sound like, how can I be guaranteed? The answer is you can't be guaranteed. You're going to have to create value that's going to bring others to you. Yeah. And you could say, well, why should I do that? Because the answer is, if you don't do it, you're going to get left behind, and having gotten left behind, you'll never catch up.
That's so true. Healthcare has to change its business model. Business model transformations have to happen alongside with technology adoption that you mentioned. I wanted to bring up one more point, and I feel that this is something that has been done in other countries and also has been done very well with Kaiser Permanente, where the patient is seen as an individual and as a number, right? I mean, you have a unique identifier that identifies the patient so that you can actually look at holistic care for that person, not only from the medical records point of view, but also their allergies and medications to, revenue cycle management, claims management, the social determinants of health, etc., so that all of the data on the patient comes together. And as you know, that while we've adopted electronic health records, there's still limitations with the records themselves because they're again data silos, and where the data is not talking to one another. What do you see in the future? Do you see a unique or unified patient identifier coming into being? Or also, how do you see these data silos being broken down?
I don't think the biggest problem is the lack of unique identifier. We could use Social Security numbers as an example. But what's the big problem? The big problem is the large manufacturers opening what's called their APIs, the application programming interfaces. This is how a third-party developer can connect with the various disparate systems and create a single record. The technology is not the issue. The identifier is not the issue. It's the fact that the large providers, particularly the largest of them, has not been willing to make this available. Now, why wouldn't they do it? Because without opening the APIs, without connecting all the systems, once a hospital system or a provider or a group of physicians have purchased a particular solution, they're not going to leave that solution. Why is that? It's so hard to re-enter all the data. It's so expensive to do so. And so as a result, the annual cost goes up, but it's better than the alternative. As soon as you open those APIs and you create a single available record, now the barriers to switching drop. And so I'm not optimistic that anyone's going to do it voluntarily. It's why I'm hoping that Congress will force it to happen, because congressional leaders will recognize that the consequences of not opening those APIs, not having that data, is that we have poorer quality, greater inconvenience, much higher costs. We could do it tomorrow, and I think it would be very valuable to do so. But as you well know, when it comes to the lobbying power in Congress, sometimes the decisions are being made for the benefit of those who are donating the money rather than those who are paying the taxes.
That's so true. So, I mean, you're right. At the end of the day, the patient does not have a say in this matter. And what's best for the patient is having all of the patient's records all unified in one place so that they can then manage it better. But we'll hope that does happen in the future. On the surge of telemedicine that you talked about, the telemedicine journey accelerated during COVID, and we saw a lot more smart solutions being adopted. But you also mentioned that stickiness did not stick through past COVID, and it hinges probably more likely on convenience and speed. So what do you think needs to happen for the telemedicine to become a norm rather than an exception?
In almost all of these areas, there are both systemic and cultural contributors. I think about it as that symbol, the caduceus, those two snakes that are wound around a single staff. You can't separate the system and the culture. Trying to do so, you're likely to get bit. So why should telemedicine drop so significantly? And I want to emphasize there are systemic things that need to happen. As an example, interstate ability of doctors to provide care. You could live 2 miles from the next state. Patients could get most of their care by driving across the state boundary to get care in your office, but you can't provide telemedicine prior to the pandemic unless you were licensed in that state. It doesn't make any sense. It's left over from 40 years ago. So the first thing would be some loosening of those restrictions. The second component to it is doctors have got to get paid. And prior to the pandemic, Medicare did not pay doctors unless they were in rural areas providing this care. It doesn't make any sense. We need to figure the process out. Many people have a fear that doctors will abuse the opportunity, but that's where I think we need to also evolve the economics of the healthcare system. Because again, in a Kaiser Permanente that's prepaid capitated, telemedicine made total sense because patients could choose the way they wanted to get care, but there was no financial advantage of doctors bringing the patients to their offices. And there's other parts. Some of the technology itself was overly restrictive. We could spend a lot of time on the system, but it's also the culture. In the culture of medicine, what doctors value is their office. They think that's the only place that great care can be provided. My own podcast, Coronavirus, The Truth, that I did before this, I asked my co-host about this phenomenon of how comfortable he would feel. And he talked about how prior to the pandemic, he was reluctant. Now it's his first choice for doctors bringing the patient to the office, the place that has their name on it. What do we call that area? As soon as the patient walks in, where do they go? To the waiting room. That's the patient's job, to wait. Now, I'm being a little, hopefully a little funny in saying all of this. It's really not our desire to make them wait. But there's no question whose time is most important. And in a telemedicine solution, everyone's time can be protected and the care can be provided so much quicker. I think with higher quality as a consequence, so much more rapidly, because you can do 5-minute visits. No one would ever go to a doctor for a 5-minute visit. What a waste of their time getting there, parking, checking and leaving. But a telemedicine visit, you can do that. It's really seeing these opportunities. And I'll go back to why I'm such a proponent of moving from fee-for-service to capitation. Because as soon as you do that, now it all changes, including the culture. Because you start to value the things that are positive for you. And when you prevent disease, everyone saves money, the patient, the doctor. Everyone benefits, the patient and the doctor. Everything becomes aligned in a way that it's not I think right now the biggest impediment around telemedicine is actually the culture, because in most places, the easing of restrictions continued, even though the frequency of utilization dropped dramatically, or the frequency dropped dramatically in spite of the easing of restrictions.
Yeah. So, what I'm hearing is that the technology exists. We can do all of this. It's just that the impediments are not due to technology, and the way we do scheduling, the way we do patient visits, etc., could all be altered, but it's just that the culture needs to change to make it all happen. And talking about culture, when you think about all the X-rays and all the digital data that we collect, image data that we collect, was all done very old world style. And now there's a new kid on the block, AI, and that has the potential for drastically improving patient outcomes. And one of its biggest application has been vision AI, that has been very commonplace in healthcare decision making. What other areas in healthcare does AI have the power of transforming?
I believe that artificial intelligence will be a major part of medical care delivery in the future. Again, it's probably somewhere in the 5 to 10 year range. But I want to separate AI into two categories, because you see, AI is only as good as the data set with which it works. So there's those things, I will say, that are visible, and in that sense, the data is excellent. Great example are mammograms. You take 10,000 mammograms, 5,000 are women that didn't have cancer, 5,000 had cancer, and you have an AI application analyze the two sets of data. You know the cancer diagnosis accurately because you do it, let's say, 5 years after the mammogram was taken. And what you find is that the artificial intelligence is actually better than radiologists at differentiating it. Now, why would that be? Because as doctors, we use what's called heuristics. These are shortcuts. We have 3 or 4 or 5 things that we say. If the cells are in mitosis with a higher number than usual, if the cells are strangely shaped, if the cells are invading, we call this cancer. AI might have 200 different things, ones we haven't even thought about as humans, in comparing these two data sets. And as long as the data input is accurate, the results tend to be better than the human mind. And so you're looking at things like retinal scans, you're looking at mammograms, you're looking at a variety of radiologic procedures, you're looking at patients who have pigmented lesions on their extremities. These are all areas where artificial intelligence has been shown to be able to achieve better results than doctors. Not perfect, by the way, but better than doctors. When we may come back to that when we look at some of the limitation. What AI so far has done poorly at is trying to use the information in the electronic health record. Now, why is that? Because we don't do a good job of putting in consistently accurate, exact information. Some of it is the fact that the medical record is about things like symptoms. 2 people say they have pain. They both say it's equally bad, but in truth, one actually might be a lot different than the other. So when AI is inside a system with bad data, and by bad I mean inconsistent and not comparable, it's going to come up with bad answers. And so I think it's going to be a long time. It'll do well, by the way, with wearable devices, because all the data is coming in and we can correlate that with what happens to the patient. Did they end up hospitalized? Did they end up with a complication? So as long as those data points are strong, we're going to be fine. I think it's going to work there. An area of tremendous interest to me has to do with artificial intelligence and care discrimination, particularly based upon race. And there was an article about, I think the headline was something like, AI is racist. And the reason it said this was because United Health did a study, or had a program really, where they said, we're going to identify the sickest people under our insurance program using AI. And in doing that, we're then going to put added resources. It was a good program. And they used an AI application to do that. And when someone else went back and looked at the database, they said, about almost half of the participants should have been the Black patient members of the health plan. And instead, it was only something like 15%. And they blamed the AI. But how did it happen? Well, as you might expect, the AI assumed, if you can say that kind of phrase, that people who got more care were sicker. The people who had interventions were sicker or needed more care, so it was logical. Really what it just did is mimic what the doctors did. We know that when we treat a Black patient, we give 40% less pain medication than to a white patient. When a woman has a mastectomy as a Black patient, we are less often likely to offer a reconstruction to the Black patients. Overall, doctors provided $1,800 a year less care to Black patients than to white patients with the same degree of disease, and the AI application mimicked it. Now, where I think the possibility is, and what's very interesting to me, is once we know this, now we can use technological tools, whether it's going to be algorithms or whether it's going to be AI, to look back and say to the physician, your pain medication is 40% less than you usually use. You sure this patient doesn't need more pain medication? 70% of the time you offer reconstruction to this woman after mastectomy. You sure in this case you shouldn't be doing it? And I'm actually hopeful that we can use AI to look at the very complex area of why Black women die 3 times as often giving birth as white women. And in that process, I think that AI has the potential to be anti-racist, not a racist technology. I think it can parallel with the things that the human brain does best. It can compensate for those things that the human brain doesn't do nearly as well.
That's so interesting that using AI to remove the biases that we see are existing in care today. And that would be truly transformational for sure. I guess we don't have much time remaining, so I would like to just ask this one last question, that in 2021, the world is still recovering from COVID-19. So in your crystal ball of the future, what does this post-pandemic healthcare world look like? What would you like to see? What would you like to see change?
I don't think it's a question of what I would like to see changed because I teach strategy at the business school, to me, hope and desire is not a strategy. I think it's a question of what will be. What Yogi Berra say, predicting the future is very hard, particularly when it hasn't come yet. So that's the sort of the framework. But I think we can look and say that the economics of the world will be very different in the future. What we can say is that the federal government will have borrowed about $8 trillion that it needs to repay. States by law have to have a balanced budget, and they're going to have more unemployment, and they're going to have higher Medicaid costs. Small businesses that are the small and medium-sized businesses are the backbone of the American economy. They account for about 155 million jobs, and they've suffered. A lot of them went out of existence. Those that are here say they don't have the reserves they had before, and they can't continue to survive with what's going on right now. And we can expect there's going to be a lot of downward pressure on healthcare, particularly around costs. And I think it's possible. I can't tell people exactly when, but I think it's possible that these businesses will come together and they will drive this change, moving from fee-for-service to capitation. It's going to be difficult for doctors. They're going to go through the 5 stages of grief. They're going to deny that it's a good thing. Then they'll get angry when it's happening. And then they'll bargain by trying to find some way to keep the prices up and keep the old system in place. And then they'll get depressed. I really worry about that, by the way. And then there is acceptance. It's not acceptance that it's the right thing to do, but it's acceptance of what will be. And I'm hopeful that throughout this process, that as we move from fee-for-service to capitation, that doctors will embrace the technology that exists and maximize it on behalf of patients. You know, if a decade ago I said to you that 10 years from now, the company that rents the most cars will own no cars. The company that rents the most houses will own no houses. And the company that provides the most content will produce no content. You'd say I was crazy. Yeah. You know, today that's Uber, Airbnb, and Google. I think we're going to see the same thing. My hope is that it will be led by healthcare professionals and not led by others, because others are not going to design it in the way to use the best parts of the physician culture to figure out how we can do what we've always wanted to do in the doctor-patient relationship, which is to be the best that we can for our patients. I'll close with a thought that a few years ago I was in Oregon at the Health Science Institute, and there I saw a sign. It said across the top, it said quality, service, and cost. And along the bottom in very small letters, it said, pick any two. That was the mindset of the 20th century. That was the best that we could do. Medical science hadn't evolved. Technology hadn't evolved. We didn't understand how to create value. Today, we can. And I think it's up to us to do so. It's going to require that we change the system of medicine. It's also going to require that we evolve the culture. I think today patients are not getting the excellence in care they deserve. I based it upon the Commonwealth Fund outcomes. Healthcare has become increasingly unaffordable for them, and physicians are burning out. And if we continue simply to do what we've been doing, I think the problems will only get worse. I think this is an opportunity to make a major change, to come together, to collaborate, to cooperate, to invest in the technologies that can raise quality and lower cost. And if we do so, we can once again make American medicine the best in the world. And again, any listeners who want more information, the website's robertpearlmd.com, and I welcome their thoughts and perspectives. Thank you for having me.
Thank you. Truly transformational thoughts. Thank you, Dr. Pearl, for taking the time to chat with us today and sharing your knowledge on the role of technology in the post-COVID era. It has truly been eye-opening, an experience that I'm sure the same goes to many of our listeners. And by the way, like Dr. Pearl mentioned, all profits from Dr. Pearl's books goes to Doctors Without Borders. So do pick up the book and read it. And if you want more information, you can visit his website, robertpearlmd.com. And dear listeners, don't forget to check the show notes for links and resources and contact information related to today's session. And stay tuned for more Care as One podcasts and discussions on trending healthcare topics that you care about. Send in your suggestions on speakers and topics, and we will try our best to address them. And do sign up for our Care as One community at community.careas1.org, where you can post your thoughts and network with your peers. I'm Dipty Desai, and I hope you have a great rest of the day.